Thank you everyone for jumping on tonight. I know everyone's got a very busy schedule and we appreciate all your time. Tonight's webinar will spotlight Dr. Baravarian and his experience utilizing the S-Core implant in Hallux Rigidus patients. Dr. Baravarian is currently a member of UCLA Medical Group, Chief of Podiatric Surgery at Santa Monica UCLA Medical Center and Orthopedic Hospital. He's also an assistant clinical professor at the UCLA School of Medicine. He serves as a co-director at University Foot and Ankle Institute. He's a diplomat of the American Board of Podiatric Surgery and one of only a handful of foot and ankle surgeons to have both foot and reconstructive rear foot and ankle certifications as a fellow of the American College of Foot and Ankle Surgeons. He's published over 100 times, written 7 books and multiple book chapters. He performed a comprehensive 3-year residency at the University of Pittsburgh, Southside Hospital, formerly St. Francis Health System, with an emphasis of sports medicine and reconstructive surgery. He's internationally recognized as an expert in bunion surgery, ankle ligament surgery, foot and ankle arthritis, and cartilage damage treatments. I could keep going on and on and on.
My God, I sound so damn old, Connor, with all that stuff you said.
And the list keeps going on and on. You've accomplished a lot of things, and
thank you.
We're very thrilled to have you on board tonight to present, and I'm going to hand it over to Dr. Baravarian.
Thank you. So, a couple things. I think you were just reading off the CV, and I'm still involved with UCLA, but I'm not the chief at UCLA anymore. I'm now the chief at St. John's, which is the sister hospital, but
right.
Same kind of same but different. So I think that this topic is an interesting one for me. Subchondral Solutions was started by a wonderful orthopedic named Derek D, who I've had the pleasure of knowing for a long time, and Derek has been instrumental in really bringing a topic to kind of like top of mind that we didn't really think about a lot, which is we've always looked at fractures as being cortical fractures, but this idea of subchondral edema and subchondral fracture is actually a fairly big deal. And the way I like to look at it is, if you think of like the roof of a house being the cortex, you have the boat truss on the inside, or you have framework on the inside under the roof that holds up the roof. That's the subchondral bone. And if you have damage to the subchondral bone, you can get sagging of the roof, you can get collapse of the roof, you can get damage within the structure of the roof, and eventually the roof will collapse. And so you see a lot of patients, if you pay attention to it, where we start to notice this idea of subchondral edema on MRIs. And it's something that you need to start to think about. It's something that should be back of mind for you. It's something that you'll see in the big toe. You'll see it in the midfoot. You'll see it in a lot of arthritic cases. You'll see it in the ankle joint. You'll see it with osteochondral lesions. And the treatment for it so far has been kind of poor. What we've really done is either not treated it, or waited for it to go away, or possibly gone in and drilled the lesion, hoping to create bone formation and creating edema to help heal the area. And what Derek came up with is a product called Subchondral Solutions that really, after you start to pay attention to it, makes really good sense. You are adding structure to the subchondral bone, and you have the ability to add a surface if there's damage to the roof. So if we think of the cartilage and bone as the roof, you can add a new lattice work that will form type 1 cartilage or type 2 cartilage, and that's the covering of the subchondral solutions. And underneath, you're adding a structure that helps to heal the underneath bone and builds a structure under the roof so it doesn't collapse. So for me, Hallux Rigidus has always been a little bit of a difficult issue. You have a patient comes into your office and you have a really, really arthritic joint that looks horrible and they have no pain. And then you have another patient who comes in the office with a tiny little bone spur, and they have a lot of pain, and anywhere in between. And you're looking and you're like, I don't know, this bone spur can't be the source of this patient's pain, and they're having pain with range of motion. And then you have another patient who's got very little range of motion, a horrendous looking joint, and they don't even complain about the hallux rigidus. They're in there because they have Achilles tendonitis. And you're looking and going, how could this be? Well, I think the thing that we don't realize is that what we've been trained to do is look at a radiograph or look at a patient's foot and examine their foot and say, based on these three things that I've learned, this is the problem. And levels of cartilage damage are the source of the problem. Well, you could have a patient who has a very small amount of bone spur and very small amount of joint space narrowing, but they have articular cartilage damage, or they have subchondral edema, and they'll have a lot of pain. And you could have a patient who has a very dense, hard cortical shell, not much cartilage, and they don't have any pain because there's no edema in the area. There's no subchondral edema. The joint itself is not really inflamed, and they don't have a lot of pain. So it's important for you to start to think about this when you start to see patients with hallux rigidus. And how do you know what's going on in the joint? Don't let the spur fool you. The range of motion limitations can be a guide, but I've seen patients with wonderful range of motion who have a lot of pain. So my suggestion to you is, if it's not a clear-cut case, and to me it's become less and less a clear-cut case, I get an MRI. And for me, the MRI is a guide to show me what the level of articular damage is, if there's subchondral edema, and it helps me with my reproducibility of what I'm going to do for the patient if I'm thinking of something surgical. If you're thinking of doing surgery on a big toe joint that is arthritic, an MRI will allow you to decide whether you need to do articular work, whether you need to just do a chylectomy, whether you need to do a decompression, whether the joint needs to have an implant put in, whether the joint needs to be fused. So really, I think an MRI is something that you should think about very strongly in cases of osteochondral lesion. And then the other one is, okay, so you open up a joint and you're going to do your chylectomy, and all of a sudden you see an osteochondral lesion. And did you look at it? Did you see it? Did you try to ignore it? What do you do when you have this osteochondral lesion? And this has happened to me more times than I care to admit. And my problem was that because I wasn't getting an MRI, I would open up the joint and be surprised by an osteochondral lesion and fairly good-looking articular cartilage otherwise. And I would drill these, and I would sometimes take the cartilage from the dorsal surface and I would morselize it and put it in. And because there was no structure to that area, I would have to be careful not to allow the patient to weight bear or be aggressive with the joint, and couldn't get them moving or back into shoes as quickly as I had promised with a chylectomy. And so really understanding that an osteochondral lesion and subchondral edema are sources of pain, and to make sure that you're aware of them and are able to treat them in a timely manner is very important. And what we want to do with everything now with foot and ankle is how fast, how well, and I think that the fast is important to patients. Patients don't want to be non-weight bearing. They don't want to have periods of downtime. They want to get back to their shoes, back to their life. And so how can we reinforce an area that's damaged, doing the best opportunity of treatment for the patient, and get them back on their foot as quickly as possible? And I think that that's where the S-Core really came into existence for me. And basically, you can have a damage to the articular surface in multiple different ways. You can have a one-time injury, such as a car tire going into a pothole, or you can have a chronic damage to the articular surface because of the range of motion of the joint, or the way that the joint is gliding, or if there's a spur in the joint, the way that it's catching. Both of those are a one-time injury or a chronic, more kind of like limited injury. And what happens is the cartilage gets damaged, you have edema of the subchondral bone, and you have what's called trabecular fracture. Trabecular fracture is what you see on MRI as subchondral edema. There's actually a fracture in the subchondral surface of the bone, and it is considered a form of a fracture. What the S-cord does is it acts as a platform to structurally repair the bone and to deliver a soft tissue allograft for a complete repair of the surface. And that's very important because we want to try to kind of fill the underside of the bone to make it strong. And then if you have the opportunity to also add something to the surface, to add a material that will mimic the surrounding cartilage and help to form a new cartilage layer, that's the ideal scenario. And when you look at osteochondral lesion, you kind of are looking for these cases to be used in a grade, I would say grade 2, grade 3. Really, once you're in a severely arthritic joint, I still think that a fusion is probably my go-to. Some people are doing total joint implants that I think are okay to do. Some people will do a hemi joint, and again, I think it's okay to do. But for me, it's really become these stage 2, stage 3 osteochondral lesions, and the S-cord can be used for lesser MPJs like Freiberg's and AVN of the lesser MPJs. It can also be used in the talar dome in the same way, but we're going to kind of try to focus to the big toe joint. So what have been our choices so far when you see an osteochondral lesion? So you can use micronized cartilage. You can use cryopreserved hyaline cartilage and then try to kind of like sew it down or anchor it down. You can use an allograft, osteochondral allograft. You can use a uni replacement in the knee. And there are osteochondral injections where you're using the demineralized bone matrix with PRP or some sort of subchondral bone filler to kind of try to fill the void or strengthen the subchondral bone. But for me, all of these require downtime, and they require a period of the patient not putting heavy weight on their foot. They can't get back to activity fairly quickly. And one of the things that really turned me on to the S-core is, number one, that it's super secure, super strong. And the second thing is that the graft material is anchored onto the S-core in a way where you have a very, very strong apparatus that patients can ambulate on day 1, back into shoes within 2 weeks. And some patients are even back into range of motion earlier than 2 weeks. And really back to activity within about 4 to 5 weeks, which is a lot faster than when you're doing it with osteochondral grafts or micronized cartilage type stuff. And if you look at the comparison to other products, price-wise, I think that the S-core is relatively a very, very reasonable price compared to other stuff. I really think micronized cartilage is kind of very low tier. And if I was going to use micronized cartilage, I would just try to take surrounding cartilage from the patient and put it back into the osteochondral lesion with some fibrin glue. I think you at least have some cartilage cells there. I think oats are difficult to do and to match the cartilage. And I think that, the S-core really has a place in osteochondral damage that is a wonderful void filler, no pun intended. And what have been the findings? So with the S-core, what you're trying to do is delay the progression of the osteoarthritis, eliminate pain, reduce swelling, return the patients to full functional range of motion and activity, and try to do it quicker, as quickly as you can. And if you compare to an arthroplasty and arthrodesis, you'll notice that the S-core is 4 weeks, where an arthrodesis is 12 weeks, arthroplasty is 8 weeks. And so the goal is, what is the least invasive, fastest way that I can get my patients back to full activity and with keeping range of motion and keeping them active? And some of the information that is important is kind of going backwards and saying, okay, tell me what this cartilage subchondral unit is. So The cartilage and subchondral unit is an interface that undulates. So best way to think about it is cartilage has a little bit of give to it, the subchondral bone has a little bit of give to it, and that allows a passage of shear stress between the two. And if you have a kind of like a uniform pattern of weight distribution, then the weight is dissipated more evenly across the entire structure, much like a well-built roof with boat trusses that are kind of putting the weight across the roof evenly. And if an area is missing or damaged, then what happens is that the surrounding area is taking additional stress, and that's why you start to see damage. If you look at cartilage and subchondral bone in the early stages, and you look at it in the late stages, you'll see that there's a hypertrophy of chondrocytes. You start to get fissuring in the articular cartilage. Then you have bone cyst formation. You have subchondral sclerosis. And so that kind of nice, healthy movement of the articular cartilage and the subchondral bone and the cortex as a unit goes away. One way of also looking at it is if we go back to the tire analogy, if you look at a good, solid, like quality tire, it's like soft, rubbery. It doesn't have bumps in it. And if you look at a tire that's been sitting on a car for a long time and it starts to get fissures and damage, and you try to drive on that tire, the tire bounces around and jumps. That's because it's not the same consistency across the board. And we want to try to return the quality of the entire cartilage surface to a solid surface. So with the S-core, it's a very simple procedure. It's 3 steps. Number 1 is finding the size of the lesion. Number 2, there's a cannulated countersink that you countersink to a depth of about 5 or 6 millimeters. And then you ream for the surrounding borders, leaving the central cortex intact, central subchondral bone intact. You put your graft onto your implant if you're going to use a graft on top of the implant. Some people will use the implant without a graft. Some people will put cartilage on top of the graft. But again, I think that your best bet is to use the graft material that the S-core product comes with. And so you sew the implant onto the S-core, and then you basically screw it into the hole. And you leave it where the graft is at the level of the articular surface. And then you have these threads that bite into the bone, and you have these fenestrations, which allows the subchondral bone to bleed and for incorporation of the S-core into the surrounding surface, and for allowing the graft to incorporate and form a form of cartilage. These kits come disposable, and so you don't have to flash them if you have multiple cases. And so K-wire is put in, fluoroscopic check is performed. You countersink to about 5 to 7 millimeters below the subchondral plate. You core a ream around the edge, and if you look, the K-wire in the far right picture at the top is centrally located, and there's a ream around the edge. The graft is sewn onto the surface of the implant, and then the implant is screwed cannulated wise into the hole. And the graft, you can see, kind of forms a nice surface area covering the articular damaged region. And so these, you can see, are a simple case where you open up, you see this osteochondral lesion. You measure, you drill, you put your graft in, and you can see what the focal repair area looks like and what the radiograph will look like. And you can see that this doesn't have to be centered like other implants. You can put this on the low end, the high end, put 2 of them in, whatever needs to be done to fill that articular cartilage damage area. And just to give you a couple of patients, there's a patient who had pain level 8 on the 12-14, and on 12-21 pain level was down to a 2. 29 months post-op pain level is down to a 0. This is a case of an ankle being done with the same material, and you can see it here. It's been used in the knee and the shoulder, and then you can see a second look at 24 months, and that's the reason I put this in. You can see the form of cartilage that you're noting, and how wonderful that cartilage looks compared to what we've had really access to up to the present. Couple of studies that I want to go over. One is the biomechanics of the first metatarsophalangeal joint osteochondral defect repairs following SCORE. And the results were fairly good with this, and they were showing that the articular cartilage was holding up, the implant was holding up, and the load strength was not putting any form of dramatic damage to the S-core. This is a study I've had the privilege of being involved with, and there was no reported deep cases of infection and no loosening in 200 cases. There was 2 cases of arthropibrosis, and I think that those are due to not allowing early range of motion, which is the most important thing. These patients should be started in range of motion almost immediately. There's another study that I have the pleasure of being involved with, and it showed that the outcomes for these studies were significant improvement, decreased pain, and excellent outcomes overall. And finally, another study that was presented showing that the outcomes for, again, the study shows that the outcomes were excellent with this form of treatment. There's also been multiple animal studies, and at 12 weeks, the hydroxyapatite implant shows good coverage and fill. And at 26 weeks, the hydroxyapatite implant's fully covered, and there's a transition being found to actual cartilage formation, which is really wonderful. Like I had said before, MRI is fairly important in these cases, and this is just showing you a case. You get an MRI and you'll see the subchondral edema. Sometimes you'll see the osteochondral lesion, and sometimes all you see is subchondral edema. If you have a subchondral edema case, I urge you to have a S-core available, so that if you open up the joint, you don't go, oh, what do I do now? It's something that you've consented the patient for. So don't be afraid. And so this is a very interesting case. If you look at the osteochondral lesion on the left, you could easily be like, you know what, it's not that bad, I can leave this. But as you start to debride the loose, damaged articular surface, you all of a sudden have a fairly large osteochondral lesion in the center portion. And if you don't take care of that, that's probably the main source of pain for the patient. The patient did have a small dorsal spur, so I did do a kylectomy. But the main issue was this osteochondral lesion. So I'm measuring, and after I measure, I put my K-wire in, I drill 5 to 7 millimeters below the surface, and then there's this needle system where you take a fairly dense graft and you sew it on. And once the graft is sewn on, you basically screw it back into place, and you can see what a beautiful surface you get. And if you look at the angle of my implant, it's not perfectly straight, but it's in line with where my articular surface was damaged. And you can see that it's buried below the surface of the articular cortex, and there's a graft that's nicely presented on top. This is another example, and you can see the shear osteochondral lesion on the lateral aspect and the resurfacing that's been performed. And this is a case where if you look, the central head of that metatarsal has a large osteochondral or articular surface missing. And so if I'm going to do a kylectomy in this case, I will do a kylectomy with an S-core and put a larger size S-core in, and then remodel around it after I've put the implant in to take off the excess bone. And this will now form a more happy surface than the raw bone surface. So you can use it in Hallux rigidus cases. I wouldn't use it in a very, very bad case of articular cartilage damage. But if you have central lesions or, even like somewhat larger lesions, it's a no-brainer to use it because you don't burn any bridges. You can always convert it to a fusion if you need. But I've been really pleasantly surprised at the reduction in pain that the patients have. And my clinical observations are, it's versatile. There's pain relief that's almost immediate for patients. Swelling reduces. You can return them to activity very early. I have patients back in therapy within a week after surgery. and I get them into shoes within 2 weeks after their sutures are removed. And I really don't restrict them very much. I tell them not to jump and run for about 4 to 6 weeks. The procedure is reimbursed. It is got a very broad coverage of care, and I also think you can start to look at it for Freiberg's and Taylor dome lesions if it's something that you need to deal with. And that's my presentation. I hope it opens your eyes to thinking about this issue and the issue of osteochondral lesions. And my email is there, bob@footankleinstitute.com. And I'm happy to answer any questions and go over any details that you guys might have or want to know about.
Thanks, Dr. Bob. Appreciate it. Looks like we might have a question in the chat. Preoperative planning with patients. Have you started to have conversations with patients for S-core? Microfracture was easy because it's just drilling. With the S-core implant, you're leaving an implant with biologic. I guess the question is, have you started to have conversations with patients for S-core?
Yeah, I think that I've opened many joints in Hallux Rigidus and Limitus cases where I thought that there wasn't going to be much damage. And I've been really burned or surprised. And I've had to, change my surgery at the time of the surgery to do something different. So what I try to do is be a little bit more proactive with Hallux Limitus, Hallux Rigidus cases. I'll give you an example. You don't open up a slightly arthritic ankle joint without knowing if there's an osteochondral lesion, but we really don't think of the first MPJ the same way. You need to get an MRI, I think, to really plan properly, to know what's going on the articular surface, the cortical surface, the subchondral surface. And so my surgery is either I'm going to do a chylectomy. If I think that their joint is somewhat limited in range of motion, I might say I'm going to do a decompression osteotomy, possibly. And if there's any question about osteochondral lesion, any question of a subchondral edema, then I say I may need to put this implant in to resurface the joint. So my choices are either a chylectomy with an S-core or a chylectomy alone if the cartilage surface is good, or a decompression osteotomy. And I usually try to have those either all three available to me or 2 out of the 3 available to me based on what I think I need, so that I have more options at the time of surgery. But more and more, I have the S-core consented for. So if I open it up and go, oh, I wish I had this, it's there for me. And I think that it's far more powerful than drilling an osteochondral lesion. Because yes, the drilling can be helpful, but you're taking a roof and you're making it less stable to hope that it'll become more stable. Whereas with this, you're taking away the bad part of the roof, you're putting in something very structurally strong, and then you're resurfacing the roof to make it work properly again. And so this is much faster recovery and much less downtime than osteochondral drilling.
Awesome. Thank you. There was a second part to that question. It may have already been answered, but do you consider shortening the first ray? If so, how so? But what type of osteotomy, and do you move more proximal because of the implant?
So I don't think you need to do a decompression and a S-core at the same time. I think the S-core in a certain way is a form of decompression slightly. Most of these lesions are central or close to central. And so that bone didn't lengthen. And if there isn't osteochondral injury, then I think you putting the implant in is basically fixing the problem, the S-core implant. So I don't do a decompression and an S-core at the same time. I think you can put an S-core implant in, and if the range of motion is good, get them back to PT. And if it still is a problem, you can always come back and do a decompression, which is not what we want to do, but I'd rather err on the side of being conservative. But if I find that I've got some articular wear without an osteochondral lesion, and the joint just seems stiff after a chelectomy, I think then a decompression is a good idea. And with that, I do like an L osteotomy with a parallel cut, plantar flex, and shorten the first mat, maybe 2-3 millimeters, maybe 2 millimeters. And then I just run a screw from dorsal proximal to plantar distal to hold it.
Perfect. There's a couple more questions. Can you share how you initially worked the patient up in clinic? From your experience, what have you learned about how to identify these patients?
Yeah, so I think there's a few different groups of patients that you'll see. One is the patients who come in and they have a little bit out of norm pain with a grade 2 osteochondral hallux rigidus case. So you don't know whether it's the hallux rigidus or the osteochondral lesion. When you put them, excuse me, when you put them through range of motion, they have pain with range of motion, even like mild range of motion, and that's the osteochondral lesion talking. And then once you start to get into a grade 3, it becomes a little more difficult because there's been more joint damage. And sometimes that bone spur that's forming is the body trying to repair the damaged underlying bone by laying down more bone. So I think that theoretically, like, you want to always have in the back of your mind, is there a possibility that there's osteochondral damage that has occurred in this area? And if there is osteochondral damage in this area, I need to be aware of it. So the workup is usually getting an MRI for me. I tend to get more MRIs on first MPJs that are hallux rigidus than not. I would say it's very rare for me not to get an MRI now, because I think that you kind of don't want to be in the surgery and be fooled. And so I think your MRI workup is going to give you a lot of answers to see if there's subchondral edema. If there's subchondral edema or an osteochondral injury or both, I will usually try to have an S-core on standby. And then if I open it up and the joint looks pretty good, I won't use it. And if it doesn't look good, I'll use it.
This looks like the last question. If patient has mild to moderate bunion, would you also recommend translation osteotomy, Austin, chevron, etc.? If patient has dorsal ray elevation, would you consider plantar flex or osteotomy?
Yeah, I think it's a little different. So you don't see that many osteochondral lesions associated with a bunion. You see it a lot more with rigidus. So I think that I look at these as two totally different issues. So if a patient has an elevated first metatarsal and is jamming, I think a decompression osteotomy is a good idea. I do think you could do a decompression osteotomy and put an S-core in. You just need to make your cut a little more proximal so that you don't damage the S-core implant. And that implant is so solid that you should be able to still get an osteotomy done and put a screw in if you really need to. But I think that medial lateral translation is more bunion driven, and I don't think that you need to do that often in hallux rigidus. But if you did, and if I open up and see that there is a osteochondral lesion, I would first treat the osteochondral lesion, because I think that's a bigger source of pain than the bunion or the medial shift. So I don't always go in and do that. I will treat the osteochondral lesion, and then if I need to go back and do the osteotomy. And I got to tell you that anecdotally, I haven't had to do an osteotomy with an S-core to date. When I've treated the osteochondral lesion, that was the source of the pain, and the subchondral edema was the source of the pain. I think if you guys start to pay attention to this topic of subchondral edema, it's an area that's been really neglected and missed. Like midfoot arthritic pain, you'll notice that joint pain, patients have more joint pain because of subchondral edema. You'll see a patient with an ankle sprain that's not getting better, and you get an MRI, and they have a lot of subchondral edema. Not always an osteochondral lesion, but that subchondral edema is basically an internal fracture within a bone. And so that needs treatment. And if you don't treat it, if you're not doing something to kind of like motivate the body to heal, what sometimes happens is it just lingers, and then it needs like what was I going to say? It needs like bone stimulator, shockwave therapy, ultrasound, um, PRP, something to stimulate the area to heal, demilitarized bone matrix, S-core, things to actually get the area to heal. So really pay attention to this idea of subchondral edema because it's there and it's relevant and it's important.
Love it. Thanks, Dr. Bob. We appreciate your time. Great presentation. He did leave his information on there, guys. So if you have any questions, feel free to reach out to any of us or Dr. Barbarian. Thanks again for your time.
Thank you. Thank you for having me. Always here.
It looks like one more question came in.
Sure.
Do you mind answering it?
Of course.
The question is, this is from Dr. Windrum. Do you suggest doing an MRI scan on bunion patients that have pain upon range of motion to determine if there is subchondral edema present?
I haven't seen it that much in bunion patients. I think if you have a bunion patient that has very limited range of motion, I would get an MRI just to be safe. I think sometimes it's the position of the sesamoids, the position of the first metatarsal head, that's the problem. And when you either do a lapidus, lapiplasty, osteotomy, and you realign that bone, you're realigning the articular cartilage, repositioning the sesamoids, and I don't see a lot of problems. The ones that can be a little bit of a problem are the bunion patients where you have a limited range of motion. And why do you have a limited range of motion? Is there some form of edema in the joint, subchondral edema, osteochondral lesion that's limiting your range of motion in the joint? Those sometimes I'll get an MRI on, but I haven't seen this be as big a problem in hallux valgus as in hallux rigidus cases.
Perfect. Well, thanks for answering that last question.
Anytime. Again, always available if you guys need.
Thank you, guys. Thanks for jumping on. Have a good night.
Good night.